believes that I have some audience. Okay, mic on. ठीक है. No, no. Pandav. तो साबी के पास है. Thank you very much for this opportunity to speak here. I'm actually representing Dr. Dogra, who had to leave early, so I hope I'm able to do justice to his talk. The question is, do we need 5.5 years MBBS in times of super specialization? Now, before we go to that, to answer that question, I think what are the objectives of the MBBS course? There are a number of objectives. I think there's a detailed document which the MCI has, but I think grossly speaking, we need a comprehensive, MBBS means we are training people for a comprehensive healthcare who could do a clinical diagnosis, who could provide solutions to health problems, not just the treatment, but the solutions to the health problems of the public, and which also include public education as well as public health. So to perform all these tasks, you basically need a very comprehensive knowledge about not only the human anatomy or the human physiology, but as the human being as a whole holistically, and also the emotional aspects as well as the environment, because health is not just the physical being, is an interaction, is a complex interaction with the biology and the psychology and also the environment. So I think to understand that complex interaction, you really need to be very well aware in all these issues and have your training in these things. So if there's the question, then why are we debating this? Then why do we really need to debate this? And so I think this is because with the rise of super specialization, now we have a lot of different kind of doctors. So we have eye doctors, we have kidney doctors, we have liver doctors, and the list goes on. And if you ask public in general, they say, okay, now we have the heartless doctors. So I think this is not very unusual to see in public. This one of the aspects is because super specialization is a little bit of glorified and a little bit of glamorized because everyone wants to be in that space. But I think there's a little bit of problem here because it's not really a super specialization. We are still under the same umbrella of MBBS, of that comprehensive care. So unless you are in that space, only then you can go super specialization. So it's actually a sub-specialization. So we should not be calling it super specialization in that sense. It's a sub-specialization. We are actually going into a very smaller domain. And this increasing trend of, this has resulted in an increasing trend of treating organs rather than humans. So, and that's again is a dangerous because the super specialists are very good in a very small field, but their knowledge and domain or its application of that knowledge is very limited. The scope is very limited. So therefore, I would say in this era of super specialization, you actually need more comprehensive doctors who can look more holistically at the patients, because the public health is not just eye disease or a kidney disease. There's a lot more to it, and we need people who can cater to that segment, and which is actually a very wider segment. Now, if you look at the the flow of knowledge and services, because medical field is a very dynamic and ever evolving field, so there's a lot of knowledge is getting generated, new skills they come, and if you look at there's a kind of pyramid, so it kind of flows from top to bottom. So the new knowledge is created in institutions, which are basically the educational institutions, teaching institutions, the research institutions, and that should go down gradually to the secondary level and hopefully to the primary level. So the comprehensive care doctor, MBBS doctor, he has to be gradually, should becoming more skilled, and some of the jobs which were done at secondary level, they should actually percolate down to the primary level. And same, there's a knowledge, and same follows the services. So services which are available at tertiary care center, they should become gradually move downwards to the secondary and primary level. But what is actually happening is just the other way around. So those who are in medical institutions, the teaching institutions and bigger hospitals, they see ever increasing rush of patients, and with conditions which could very well be treated at a secondary level, if not primary level. So why is this a reverse trend? Actually, if you go by the logic, it should be, the trend should be other way around, but this is not happening. So what is the reason for that? The reason for this is because the comprehensive care doctors, they are, that knowledge which should flow from top to bottom actually is not flowing in that sense. So the comprehensive care doctors, they are not actually being updated. Now, AIUS, like ophthalmologists are updated through AIUS, you know, heart people, they have their own specialization, kidney have their own societies. So the individual super specializations, they have a mechanism of updating their cadres, but who is doing this for MBBS? So I don't think there's anyone who's doing any such conferences for at MBBS level. Most of these doctors would be in the government jobs, and they actually have no opportunities to train themselves or upgrade themselves, or even you know, motivation to do that. So what is happening is that the skill level, which should be improving constantly, probably is not happening. And when that happens, they will not take up the newer challenges, the newer diagnostic. So, and that also means that the public, because public is very aware these days, so I think there's a little bit erosion in value at that level, and that's why the people are preferring to seek treatment at secondary or tertiary level, thereby burdening those institutions. So I think the problem here is that that means that our MBBS doctors must be empowered. They must be provided more opportunities and, you know, more so that they can update themselves, so they are, you know, they can take care of the changing needs of the health sector. But what is being proposed here is actually going to reduce the capabilities of the generations of doctors which are going to come. Because if you cut down their course to 3 years, obviously you are cutting down on a lot of things. So the comprehensive doctors actually becomes very limited in its capacity, which is already actually restricted. It becomes more restricted. Now that is not a good thing to do, because this will have more consequences. So what's going to happen is that if you look at this is a kind of a spiral, the knowledge and skill is a spiral. So if the comprehensive doctor or MBBS doctor has less skill, less knowledge, you know, 5, 6, 7 years down the line, some of these doctors will move to the apex, because there is no alternate stream of, you know, there's no alternate way of taking people in at that level. So some of these people only go to those positions, the research and teaching positions. But if their skill level is already low, so you will have people have a low skill level at the higher, and then this is spiral down to kind of a less skill, less, you know, generation of knowledge, less generation of new skills, and less, you know, patient care. And that will set up a very vicious kind of a cycle, which will move the primary care upwards and secondary care even upwards to the tertiary care. What will happen eventually, we get even at the tertiary care level, because of the degradation in the skill level, there is going to be, people will not be happy there, because they will not get the service they should get. So this is going to be very detrimental to the entire health system. So I don't think that's really the way to go. The other thing is that there's going to be a loss of parity with the international programs, because the source of knowledge is varied. I mean, a lot of knowledge is generated abroad, and we all, you know, go abroad, we do fellowships, we study their programs, we invite them, because there's a parity between their program and our programs. But if our program is substandard, then that cuts off, you know, those avenues. So that will restrict the eligibility and opportunities for higher learning in foreign countries and foreign institutions. And the reality is that we depend a lot on other institutions to learn things which we bring back home to India and teach to, you know, other students. So this is going to be in the longer very detrimental to the quality of the research education and ultimately to the patient care. So I think a reduction in MBBS course, to my mind, should never be done. Instead, we should refine it, make it more relevant to the changed environment of practice, changed needs of the society. And what is lacking is actually as in leadership, advocacy, some administrative and research opportunities, which should be built into the MBBS course, so that they are better trained to handle the pressures of, you know, the administration and the pressures of the public life better. And also to create opportunities for continued learning of doctors at the lower level, because the majority of the healthcare, 80% of the healthcare is actually at that level, not at the tertiary level. So the job of the tertiary level is to create knowledge, to, you know, new knowledge, and percolate it down, create skills, percolate down, you know, so that the people where the most of the population lives, they get this benefited. So I think this is how we should go about it. Thank you very much.
Thank you, Dr. Pandav. I think that was very well discussed. On the one hand, there is now a demand that if there are 40,000 graduates coming out, there should be 40,000 postgraduate seats. Then comprehensive ophthalmologist is not left anywhere. I mean, you don't leave a postgraduate.
Well, I think because as it is the MBBS, I think to my mind that should not be done actually. We need that platform, we need that general doctor. But if we want post-graduation, then we have more post-graduation as family practice or a general practice post-graduation.
Yeah, that may be a good idea.
So that means they get a platform.
Provide an opportunity for them to develop.
Yes, because these doctors, they need to update their service. And what is happening is no one is looking after the interest of an MBBS doctor. So he doesn't belong anywhere. The government doesn't provide an opportunity. The infrastructure is less. They will not get leave to attend a conference. They will not get sponsored for a conference. And also,
where does the primary care grow?
Where
go
the
if there is no comprehensive comprehensive.
I mean, these are the ones who do the primary service, primary and secondary level basically. So, and that's where our services are suffering. So, more people from primary level patients, they're going to the secondary and secondary level. They should be treated at secondary level, but they prefer to go to the tertiary level because there is kind of erosion in value, and that erosion in value has happened because of that lack of continued development of these doctors as professionals, and also the infrastructure, because I think both are lagging.
I think the remedy lies in giving them a better stature and better training, better education to work as comprehensive.
I think, yeah, that's true, but I think stature is something that you can't really give to somebody. That is because that has to happen, and that will happen by your professional conduct. So that means you kind of, again, it comes from empowerment. You empower those doctors, they have to have this.
More CPD
you have to build that confidence.
Continued professional development.
Yeah, we have to build that confidence in that cadre of people. Look, we are doing a job and this is how it is to be done. But that would be done only with the continued education. And once there's a continued education, once they do a good job, they themselves would be in a position to actually demand better infrastructure and create better infrastructure.
Thank you, Dr. Pandav. That was very good.
Thank you, sir.
पहले बोल दो, महिपाल